Good morning, everyone. I hope everybody's having a great morning. My name is Dr. Reyes. Before I get started on the presentation, I wanted to ask if anybody had any questions about the program or anything that maybe I can answer. No questions? Okay. So we're going to get started, and this meeting is being recorded. Can everybody see my PowerPoint presentation?
Yes, I do have a question.
Yes.
Is this PowerPoint available to download or print?
I will send it out to faculty and they should be able to put it on the announcements in their courses.
Okay, thank you.
Okay, perfect. So we'll get started and then we can leave all like questions regarding the presentation at the end because I can, sometimes it's hard for me to look at the chat and stuff like that. All right, so this presentation is on Introduction to Antidepressant and Anxiolytics. So the general principle of antidepressant or any psychotropic in that matter is patients who receive treatment with any antidepressant often experience improvement in their symptoms. And when this improvement reaches the level of 50% reduction of symptoms or more, is called a response. The goal is complete remission of symptoms while maintaining that level of improvement so that the patient does not relapse shortly after remission, nor does the patient have a recurrent episode in the future. Neurobiology of depressive disorders. There's three major neurotransmitters that have been implicated in the pathophysiology of depression. We have the norepi, dopamine, and serotonin. In recent studies, they're also studying glutamate has attained a key theoretical role in the hypothesis of schizophrenia, as well as in a number of psychiatric disorders, including depression. So there's a lot of research going on right now. Like glutamate is one of the receptors they're attacking in newer medications. Neurobiology of depressive disorders, the hypothesis, the monoamine hypothesis of depression is a hypothesis involving deficiency of monoamine neurotransmitters. Neurotransmitters receptors hypothesis of antidepressant action is a hypothesis involving monoamine neurotransmitter and their receptors. Antidepressants make more neurotransmitters available in the intrasynaptic area of the brain, therefore stabilizing the person's mood. So, categories of antidepressants. These are all the different categories that providers can pick from, and we'll just be discussing each of them in this PowerPoint presentation. So, how do selective serotonin reuptake inhibitors or SSRIs work? Selective and potent inhibition of serotonin reuptake, also known as inhibition of the serotonin transport, or SERT. When an SSRI is given, the 5-HT rises due to the blockade of SERT. 5-HT rises to greater levels in the somodendritic area located in the midbrain. When the 5-HT rises, they stimulate nearby 5-HT1A receptors. Over time, this increases in 5-HT causes the 5-HT1A autoreceptor to desensitize, and it starts increasing. So that's why a lot of medications take, weeks to work. It's like an adaptation, and it starts increasing slowly in the brain. These are very helpful videos I've attached to the PowerPoint presentation that can give you a close-up on how it works in the receptors. So different SSRIs, we have Prozac, Zoloft, Paxil, Lovox, Celexa, Lexapro. I'm sure you guys have heard of them in clinicals, or if you guys work in psych, very common. If somebody can mute. General side effects of SSRIs. General side effects are headaches, dizziness, tremors, anxiety, and insomnia in the central nervous system. Hyponatremia, low sodium, mainly in older adults. So in older population, make sure that you start really low and slow. Sexual dysfunction, 50% of patients get sexual dysfunction, usually decreased libido, erectile dysfunction, and inability to achieve orgasm. So that's something we need to assess whenever we have anybody on SSRIs. And excessive sweating in 20% of patients. General side effects in the gastro system, we got nausea, diarrhea, loose stools, weight loss, or gain. Anticholinergic effects, usually in tricyclide antidepressants, we have dry mouth and sedation. And then discontinuation syndrome, very common. If they stop abruptly, they'll get agitation, nausea, dizziness, dysphoria. The other serotonin partial agonists, that's another category of antidepressant. This one combines XERT inhibition with a second property, 5-HT1A partial agonism. When serotonin partial agonists are administered, about half of the serotonin transporters are SERT and half of the serotonin 1A receptors are occupied immediately. With the SSRI, it's dosed so that 80% of XERT is blocked. On the other hand, serotonin partial agonist is dosed so that 50% of both XERT and 5-HT1A receptors are occupied. So it doesn't occupy all. There's not a lot of serotonin available compared to SSRI, and this is good for sexual dysfunction. And one of the most common medication is vilazodone or Vibrant. Very commonly used for depression and a good option also for people that have sexual dysfunction. Vibrant would be a good option for them. FDA approved for major depressive disorder. It comes in 20 or 40 milligram tabs. SSRIs combine SSRI with 5-HT1A receptor partial agonism. Metabolized by the CYP453A4, used cautiously with any inhibitors or inhibitors of that enzyme. SNRI, serotonin norepinephrine reuptake inhibitors, another class of antidepressants. SNRIs combine the robust XERT inhibition of the SSRI with various degrees of inhibition of the norepinephrine transport net. Net inhibition increases dopamine in the prefrontal cortex. Nets have a greater affinity of the dopamine than they do of norepinephrine. So they will also enhance dopamine levels. So we also can keep that in mind. This is good for people that have low motivation, low energy. SNRIs will be a good option for them. Overview of major SNRIs, clinical indication used to treat depressive disorders and other conditions, useful for patients with pain syndromes, debatable if they achieve higher remission rates than SSRIs. General side effects, nausea, dizziness, insomnia, excessive sweating, constipation, dry mouth, decreased appetite, headache, and sexual side effects. Another class is selective norepinephrine reuptake inhibitors, NRIs. This class of medication includes atomoxetine or Strattera, reboxetine, are antidepressants that have a selective action of norepinephrine transport net. Net inhibitors not only raises norepinephrine diffusely throughout any neuronal projection, but raises dopamine levels in the prefrontal cortex. This higher degree of net occupied the selective net inhibitors may be necessary for an optimal efficacy for either depression or ADHD. We have norepinephrine dopamine reuptake inhibitors, NDRIs, which include bupropion or Wellbutrin, inhibits the reuptake of both dopamine and norepinephrine. And NDRIs block the transporter net, and that net blockade in the prefrontal cortex leads to an increase of synaptic norepinephrine, thus leading to increased synaptic dopamine as well as norepinephrine in the prefrontal cortex. So usually, medications like bupropion and Wellbutrin, they do really well with individuals with depression, and it's used off-label for ADHD. But usually they don't work well if the client has anxiety, so we have to be very careful with that. Wellbutrin activating decreases appetite, can be problematic for patients with anxiety or irritability. Can produce false positive urine test results for amphetamine, so we also have to watch for that. No sexual side effects. Can be used as an adjunct. If your client is on SSRIs or any medication that can cause sexual dysfunction, you can use Wellbutrin as an adjunct, and improves concentration. Side effects: agitation, insomnia, headache, vomiting, tremor, tachycardia, dry mouth, rare risk of seizures, avoid in patients with binge or purge behavior or eating disorders. Black box warning: monitor for increased risks of suicide in children, young adults, and adolescents. Monitor for serious neuropsychiatric events. Serotonin antagonist reuptake inhibitors, how does it work? Clinical indication: useful for treatment of depression, used to manage insomnia in patients with major depression. It can augment the efficacy of antidepressants and block serotonin 2A and 2C receptor, as well as serotonin uptake. SARI, 5-HT2 inhibitors, both antagonists and agonists of serotonin, less effect on neuroepi, affects multiple serotonin receptors, less sexual dysfunction, anxiety, or insomnia. Some side effects are orthostatic hypotension, drowsiness, dry mouth, blurred vision, and vomiting. Black box warning: monitor for increased risks of suicide in children, young adults, or adolescents. An example will be trazodone, which is approved for MDD, off-label for insomnia at low doses. Dosing include 50, 100, and it can go up to 300. But we're gonna use lower doses like 25 and 50 for insomnia if they're having difficulty sleeping. Short half-life: antagonism of 5-HT2A and 5-HT2C, has both antidepressant and sedative properties. Less sexual dysfunction, anxiety, or insomnia. Side effects: orthostatic hypotension, priapism, drowsiness, dry mouth, blurred vision, nausea, and vomiting. Again, black box warning for young adults and teenagers and children. Alpha-2 antagonism action, tetracyclic antidepressants. The precise mechanism is unknown. This autoreceptor provides feedback to both the serotonergic and adrenergic systems. Alpha-2 antagonism is another way to enhance the release of monoamides and exert an antidepressant effect or action. Alpha-2 antagonism block neuroepi from turning off serotonin release, resulting in more serotonin, at the same time stimulating the norepi systems by inhibiting the negative feedback of norepi release. When alpha-2 is blocked, it tells the neuron to synthesize and release more serotonin and more norepi. Remeron, FDA approved for major depressive disorder. Formulation or dosing can come in 15 or 45 milligrams. Can be utilized for as a hypnotic at lower doses again. And it's a good medication to augment for depression. So at higher doses, you'll be attacking, after 30 milligrams, you'll be attacking more of the depression. Increases serum cholesterol and triglycerides, so make sure you're doing your lab work. Very sedating at lower doses, activating at 30 or above. Associated with weight gain. Side effects: somnolence, increased appetite, weight gain, no sexual side effects, rare agranulomatosis or neutropenia. Again, black box warning for young folks. Tricyclides, TCAs. These are the different medications in the class of TCAs. And we'll go over that. So tricyclic antidepressants block reuptake of norepi and are antagonisms of the histaminic receptor, the adrenergic receptor, the muscarinic cholinergic receptor. So this is a different class of antidepressant that works very differently, and we also have to be very careful because of all the side effects it can cause. So being an antagonist of H1 histaminic receptor blocks the action of histamine. The adrenergic inhibits smooth muscle contraction. This is a major use are for hypertension and for symptomatic benign prostatic hypertrophy. Antagonist of muscarinic cholinergic receptor, competitive blocking the cholinergic response manifested by acetylcholine binding muscarinic receptors. So these are the different blockades of this type of medication. They also block voltage-sensitive sodium channels on A, B, and C. Some tricyclic antidepressants are also potent inhibitors of serotonin reuptake pump A, and some may be additionally be antagonists of serotonin 2A and 2C. Works with sedation and increase of dopamine and norepinephrine actively in the frontal cortex. Now, with TCAs, they block reuptake again of norepinephrine transport. Some TCAs have greater serotonin inhibition, other more selective norepinephrine inhibition, high protein binding, high lipid solubility. Many side effects can be identified: anticholinergic, antihistaminic, and antiadrenergic. So we have to be very careful who we prescribe these medications to. Can cause sedation, increase anticholinergic action, can cause hypotension and dizziness, and can be lethal in an overdose and cause QT prolongation. So if a client has a severe history of suicide attempts by overdose, definitely TCA wouldn't be an option for me. Once the client overdoses on TCA, block voltage-sensitive sodium channels in the brain and the heart results in coma, seizures, arrhythmia, and death. And a seven-day supply of an overdose can be lethal. Anafranil, it's a TCA approved for obsessive compulsive disorder. Dosing comes in 150 to 50, taken at bedtime. Side effects: dry mouth, constipation, blurred vision, metallic taste, urinary retention, sedation, weight gain, sexual side effects. Black box warning, again, with the young folks, and then also follow the Beers criteria, which is a list of medication that should be avoided in the older population because of the cholinergic properties. Tofranil, FDA approved for major depressive disorder, off-label in the treatment for generalized anxiety, chronic pain, sleep terror, sleepwalking, nocturnal enuresis. Dosing comes in 150 to 300 for depression. Again, side effects: dry mouth, constipation, blurred vision, dilation of pupils, metallic taste, urinary retention, weight gain. And again, monitor young folks and the elderly population if they're going to be put on TCAs. Monoamine oxidase inhibitors, or MAOIs, the first clinically effective antidepressants to be discovered, were inhibition of the enzyme MAO. The enzyme MAOA metabolizes serotonin 5-HT and norepi, as well as dopamine, and inhibition increases serotonin, norepi, and dopamine. So it works on all three. MAOB metabolizes dopamine, but only metabolizes 5-HT and norepi at high concentrations. In results, they do not have antidepressant efficacy, and inhibition increases dopamine. Clinical indications: used to manage depression, primarily due to inhibition of MAOIA. And antidepressant efficacy also believed to be achieved due to concurrent inhibition of both A and B. MAOIs are also used to manage Parkinson's disease. Action inhibits enzyme responsible for metabolism of serotonin, dopamine, norepi, and tyramine. Increases level of norepi and serotonin in the central nervous system. interacts with food, low tyramine diet, non-selective monoamine oxidase inhibitors, particularly effective for atypical depression, overeating, oversleeping, rejection, sensitivity, mood reactivity. MOIs are usually not used as much anymore. It'll be more of a last resort if you've been, if they have severe treatment-resistant depression, you'll see clients on them due to the dietary restrictions. So we have to avoid high foods in tyramine, and that includes, we'll go over it on the next one. All right, here, H cheese, curd meat, broad beans, pots, draft beers, and it's just too much of a dietary restriction for a lot of folks. So if you are gonna be prescribing this type of medication, they have to be very much educated on their diet and what they can and cannot eat. If they are to be eating all these foods, it can cause a hypertensive crisis. So the systolic pressure can increase over 120, can cause headaches, palpitation, neck stiffness, nausea, vomiting, sweating, usually and end up in the hospital. Medication avoidance, other antidepressants, stimulants, because it attacks all the type of neurotransmitters. So you can be mix and matching with other medications as well. Side effects: dizziness, headache, orthostatic hypotension, dry mouth, constipation, weight gain, sexual side effects. If you are going to be switching somebody from this class of medication to another, there has to be a washout period. Do not use any other medication. Like if the client is on fluoxetine has a high half-life. So you have to take them off fluoxetine, wait a while, and then start this medication to make sure that everything has been washed out and ensure that they don't get a hypertensive crisis. So washout period, wait 2 weeks after stopping an MOI or to start another antidepressant. Tyramine-rich foods, beverages with caffeine, red wine, homemade beer, sour cream, yogurt, avocado, soy sauce, chocolate. These are just examples. Major guidelines for antidepressant use. So some guidelines that we could follow is antidepressant efficacy is similar. So selection is based on past history of response, side effects profile, and coexisting medical condition, cost, and availability. There is a delay typically of 3 to 6 weeks after therapeutic dose is achieved before symptoms improve. New guidelines say that once you start them on a dose, wait 2 weeks. If you don't have a response in 2 weeks, you can increase the medication. If no improvement is seen after at least 2 months with an adequate dose, switch to another antidepressant or augment with another agent. New research say that if you do not see any changes on a starting dose in 2 to 3 weeks, increase the medication. Anxiolytic agents. Anxiety and fear is regulated by the amygdala center circuit. Worry is regulated by the cortical striatal-thyrocortical circuit. Overactivation of the orbitofrontal cortex and anterior cingulate leads to fear. Overactivation of the dorsolateral prefrontal cortex and the CSTC may lead to worry and obsession. These circuits may be involved in all anxiety disorders. So types of anxiety disorders are generalized anxiety disorder, panic disorder, social anxiety, specific phobia, separation anxiety, selective mutism, and agoraphobia. Neurochemistry of anxiety usually is these are different systems where anxiety can happen. Dysregulation of dopamine, serotonin, glutamate, cortisol, serotonin releasing hormone, and GABA. Benzos modulate excessive amygdala activity. Some theories explain mechanism of action. Enhance inhibitory action of postsynaptic GABA A and binding on alpha-2 subunits, blocking excessive release of glutamate, which causes less anxiety. Glutamate is the activation, and GABA, think about it as more of the calming. Binds to benzo receptors to enhance GABA effects to help clients relax, and is a scheduled controlled substance. So make sure with benzos is very tricky because a lot of people use it for short term until an antidepressant starts working. You have to be very careful because clients do build tolerance and they get used to the fast acting effect. And sometimes they'll come in and tell you they don't want to take the SSRI, that the benzo works better, but we cannot have clients on it long term unless they have like a chronic condition and it's used for very different things. Uses for benzos, insomnia, anxiety, alcohol withdrawal, muscle spasms due to a variety of causes, including tetanus and cerebral spasticity. Epilepsy, clonazepam is used, anesthesia and sedation for endoscopies also use benzos. The choice of drug as hypnotic and anxiolytic is determined by pharmacokinetic properties. Very common one is Xanax, approved for anxiety and panic disorder. Half-life is 6 to 12 hours. Doses, a starting dose is 0.25 up to twice a day. Therapeutic dose is 0.25 to 10 milligrams. Again, black box warning, avoid common use with opioids, monitor patients for sedation and also abuse. It's part of the Beers criteria, so definitely do not put the elderly on benzos unless they've been on it for 20 years, and at that point you would probably have to leave it. Benzo side effects, most common side effects, sedation and drowsiness, ataxia, and memory impairment. Other side effects, headache, GI upset, skin rashes, reduced libido, extrapyramidal action are rare. Paradoxical behavior effects and perceptual disorders, hallucinations can occur. Flumazenine reverses the sedative effects of benzos. Serotonin agents. Antidepressants are leading agents to manage anxiety disorders. Serotonin 1A receptor modulate anti-anxiety effects of SSRI. SSRI effect believed to be associated with changes in functional or expression of 5-HT1A receptors, reduction of anxiety and fear. FDA approved SSRI and SNRIs for generalized anxiety disorder. Paxil or paroxetine and escitalopram, effexor and duloxetine, are all used for generalized anxiety disorder. Non-benzo, we have Buspar, buspirone, considered a generalized anxiolytic agent. Buspirone is believed to have partial agonist action at pre and post-synaptic 5-HT1A. FDA approved for anxiety, starting dose 5 through 10, 3 times a day. Therapeutic dose 30 to 60 milligrams. And Prazosin, alpha-1 adrenergic antagonist. Prazosin, used off-label for nightmares and PTSD, possibly reduces the corticotropin-releasing hormone, reduces non-rapid movement in stage 1 of sleep. Starting at 1 milligram, 1 milligram times 3 at night. So 3 pills, 3 milligrams. Increases by 1 milligram until nightmares improve. And it just depends on the client. And also watch for blood pressure. Side effects, dizziness, drowsiness, headache, urinary frequency, impotence, adverse effects, tachycardia, orthostatic hypotension, and palpitations. All right. I know it was a lot of information. Does anybody have any questions? No questions? So what I'll be doing is I'll be sending the PowerPoint and the presentation to your faculty, and they should be able to post it on your announcements in your courses. All right, everyone. If nobody has any questions, have a great morning. I will be sending these out, and hopefully you got a lot of good information from it.
Thank you so much.
You're welcome.
Thank you.
Bye.
Thank you. Thank you, Dr. Harris.